As I mentioned yesterday, AMD has the pleasure of providing 2 formal orations at every Congress, and this year Adult Medicine made a very active decision and a deliberate decision to ensure that our 2 orations were given by prominent Australian medical women. Yesterday you heard Helena Teed give an extraordinary talk about some of the issues and concerns that she has about the place of women in Australian and contemporary medicine. The Cottrell Memorial Lecture is the second of our major orations. This memorial lecture has been delivered continuously for about 20 years and was made possible by a bequest from the late Dr. Jack Cottrell. Jack undertook his medical training in Australia and subsequently worked in England, and during World War II served with the New Zealand Army Medical Corps. Following the war, he stayed in Europe and was instrumental in the establishment of what became the World Health Organization in 1947. He was a pioneer who made valuable contributions to WHO's work, and during that time was known to be always ready to advise and assist younger colleagues. He was accused of being a communist at the height of the Cold War, and an accusation that at the time carried major implications for one's career. To that accusation, he replied, I'm in a position which gives me the opportunity to improve the lot of mankind, and if that makes me a communist, so be it. His contribution to World Health through the WHO reflected his idealism, but also his determination to make a contribution to the welfare of people around the world. Jack's bequest to the RACP Foundation has enabled disbursements through the Cottrell Research Establishment Fellowship and the Cottrell Lectureship, this lectureship, to support the study of epidemiology and the social and community aspects of medicine. I'm delighted that today's Cottrell lecturer is Professor Anne Duggan. Anne is a gastroenterologist who I've known for many years. Anne has had major roles in clinical governance at Hunter New England Health, is a conjoint professor in the School of Medicine and Public Health at the University of Newcastle, and is currently working for the Australian Commission on Safety and Quality, and has been instrumental in the work that the Commission has led in this country on understanding variation in care, an issue we've already heard something about throughout the last 2 days. So please join me in welcoming Anne.
Thank you, Grant. I'd like to start by acknowledging the traditional owners of the land on which we meet, the Gadigal people of the Eora Nation, and pay my respects to elders past, present and future. I'd like to thank the College for the great honour of presenting the Cottrell Lecture. I think Jack Dinham Cottrell, as he was known to his friends, was a man who had a great humanity and a great sense of the best for the community in the area of health. I think if he ever had the opportunity to meet Elinor Ostrom, they would have been good friends. Elinor Ostrom is one of my heroines. She shared the Nobel Prize in Economics, one of the only women to do so. And she shared it for her work on the governance, especially of the commons. And anyone who remembers their days of high school history will remember that the commons was that area in the late Middle Ages, the English village, where everybody, the grassy knoll, where everyone was able to graze just a few sheep or just a few cattle, and it sustained them, and by sharing it fairly, it sustained the village. Overgrazing led to the death of the commons. And Ostrom has looked at common activities, economic activities like fishing, forestry, and agriculture, and how humans work together for the betterment of the community. Well, I think the Australian healthcare system is a commons. It's publicly funded by Medicare. It has universal access, it's based on equity for all, and it's a limited resource. As a limited resource, therefore, we need to ensure that we are sharing the commons and ensuring the health of the commons. And I think we as physicians have a major role in doing this. We expect to see variation in the usage of the commons because, as Jack pointed out, and he had a great interest in epidemiology of disease, there is differences in our need for health resources based on the epidemiology of disease and how it affects other people differently. And of course, we all know as physicians about the social determinants of health and how that determines illness and well-being. And of course, there's individual preference. Not all of us will choose dialysis if we ever get renal failure. But there's also unwarranted variation, and that's been on the forefront of the college's mind for a number of years now in the Evolve project. That's where low care is provided when it's not needed. That shifts the balance of benefit to harm. But there's also situations where there's high care that's not provided, and that again is not healthy for the commons. If you think about the ideal features of the commons, I've listed really, they're the dimensions of quality. I want to focus on appropriate care, appropriate warranted variation, but I think the first thing we have to recognise is if we don't have a well-governed commons overall, then we won't be able to achieve the individual goals. I like this headline from the New York Times, which the runner is, "In hospitals, boardrooms are as important as operating rooms." And the article makes the very important point that if you have a loved one who's having a heart attack, you want to get to the emergency department as fast as possible, and you want to ensure that your loved one gets the best care. You're probably not thinking, but what happens in the boardroom determines what can happen in the emergency department. So governance is incredibly important. I just want to then go to, I think, one of the major advances we've had in healthcare in Australia in recent times. The Australian Commission on Safety and Quality in Healthcare, which is a Commonwealth entity whose role is to lead and coordinate healthcare improvements for a safe and sustainable system, developed the first edition of the National Safety and Quality Health Service Standards for the accreditation of all hospitals in Australia and day surgeries. And they came out in 2013. And what you see before you is the second edition, which will be in use as of next year. And as you can see, there are two overarching standards, one about clinical governance and one about partnering with consumers, because it is for the consumers that the whole system is designed to run. Now, the lawyers will say post hoc ergo hoc is a great problem, but I do, and it is quite possible that, and absolutely correct, that there are a number of initiatives going on in healthcare. We can't say that the introduction of accreditation and a national accreditation scheme has made a difference, but certainly we have seen a difference subsequent to that, and I won't go into detail, but just to say that one of the things that we've seen in terms of better governing of our hospitals is that in 2010, there were only about 35% of hospitals had early warning systems, but come 2015, 96%. So governance of the healthcare commons is so important. That led in New South Wales to a 50% reduction in in-hospital cardiac arrests. All of us are working in this space, and the accreditation standards can't take credit for all, but it just shows that we can make advances. So what about variation? I think the landmark study on variation was the one by Glover, which he published in 1938. He looked at tonsillectomy rates among school children in England, where each of the school districts had a school doctor who made decisions about whether somebody needed a tonsillectomy or not. It was interesting, and the three things that I took away from that landmark study was, one, medicine has vogues. So he grew up in an era where nobody he knew had a tonsillectomy, and suddenly his son was surrounded by people who were having tonsillectomies. The second thing he noticed was there was marked variation in the rates of tonsillectomies between school districts. And he couldn't, despite a very extensive, beautifully done paper, find any rhyme or reason to that. It was inexplicable from his point of view. The third thing that he found, though, was there was an unrecognised morbidity and mortality related to that healthcare activity. A very important point. But, of course, that was 1938. We have moved on. There's been great advances in medicine. We now know much more about medical statistics, research methodology, epidemiology. We can assess the value of diagnostics and therapeutics. And we train and credential clinicians. And we, as I said, accredit healthcare institutions. So one would think that we don't have a problem with healthcare variation that is unwarranted. Well, the Commission started work on in terms of variation in many ways in response to what we were hearing in the system about concerns and material problems in terms of unwarranted variation. The first work we did was in 2014 with the OECD, where we found that our rates in some areas were much higher than other OECD countries. Our rates of hysterectomy, our rates of knee replacement, And that led us to then look more closely at what was going on in Australia. So the second Atlas of Health Aviation, what's called the 2015 Atlas, looked very much at, used the data sets of the PBS and the MBS. In the PBS, we looked at our use of opioids, of antidepressants, anxiolytics, antipsychotics, ADHD medication. We also looked at antibiotics, an incredibly important issue currently. We also used MBS data to look at the rates of investigations, such as colonoscopy. Being a gastroenterologist, that was of great interest to me. Back surgery and radiology. In the 2017 Atlas, we looked at topics such as chronic disease and admission rates for chronic diseases, which we would classify as potentially preventable if we had our systems in place in the community, if we had educated our population to be able to manage their disease in the convenience of their own home. We also looked at women's health and surgical items and a number of other items. The reason, in doing this, we recognised that we needed to talk to clinicians, to jurisdictions, to consumers, and of course we got the benefit of epidemiologists and data representatives. But those three groups we recognise are incredibly important in making change in the system. Some of the results, just high level, surprised everybody. In 2013 and 14, we dispensed over 30 million prescriptions for antimicrobials. We've been talking about this topic for a very long time. It's only when you compare it to other countries that you really see the problem we have in Australia. The rate per 1,000 people in Canada at that period was 642. Now, we all know that we're heading towards a train wreck if we don't do something about antimicrobials and the emerging resistance. We looked at knee replacements. Again, looking outwards to the rest of the world, our rates per 100,000 were much higher than Canada or France. And then we looked inward. Now, I'll give you an example of just the diabetic complications hospitalisation to tell you the structure of the Atlas. The Atlas data is all online. You can see your region and you can compare it to your state, the rest of your state, or to Australia. But just looking at the diabetic complications, what we did was we looked at the data based on where people lived. Not where they received their treatment, but where they lived, because that gives us a much better idea of the impact of the tyranny of distance that we suffer in Australia. We looked at it by region, what's called Statistical Area 3. That's 30,000 to 130,000 people. There are just over 300 across Australia. And then so that we could compare regions, we age and sex standardised the data. And then what we did in terms of this visualisation, for example, is we got the data and then we ranked it and put it into deciles per 100,000, with the highest decile being the dark blue and the lowest decile being the yellow. And in some areas, like up in Darwin, the data it has to be interpreted with caution because the rate's so low, or for reasons similar to that. So what you see in this atlas depiction is in inner Australia, in rural and regional Australia, we have very high rates of hospitalisations for diabetic complications, and yet we know we have models of care where people should be able to live at home. So it raises the key question of whether in those regions you have access to a diabetic educator, you have access to a dietitian, a podiatrist, an ophthalmologist, all the things that prevent you progressing with your diabetes. If you look by comparison at the capital cities, and I've just taken a snapshot of some, if you live in Sydney, you have much lower rates. You probably have access to all those things you need to be able to manage your diabetes in your home. And you probably have access to a GP without having to go to the emergency department. You can imagine if you live out in remote Australia, you probably, once you get to the hospital, it becomes better to stay there. But is that satisfactory health in 2014? Now, if you look at this graph, what it shows you is the size of the dots are the volume of activity in those regions. Then they're ranked, because once they're age and sex standardised, to the rates per 100,000. And then what we did was we took the highest rate areas and the lowest rate areas to provide some more data to start the questions about why is it so. In the diabetic complications, as you can see, it's Northern Territory, Queensland, far north Queensland, remote Western Australia. And the lowest rates are in around the capital cities. That's in stark contrast to many other aspects that we looked at in the atlas. If, for example, you look at colonoscopy, you see colonoscopy rate, the MBS colonoscopy rates are really high around the capital cities, and the centre of Australia looks very pale yellow. Now, that's a very important issue if you contemplate that bowel cancer is the second most common cause of cancer in our society, and it's a highly preventable disease. So the function of the atlas was really to stimulate discussion. So here is another example of how we've provided data. We provided data also by states and territories. So each of the states and territories, the jurisdictions, could look at their data and work on their areas of issue. This one is about looking at the remoteness and socioeconomic status. And as you can see, the rates are higher in outer regional and remote Australia. In terms of socioeconomic status, which is those, they're low and that's high, you can see that we're not getting the message across, perhaps in terms of we're not addressing as much as we should health literacy, one would suspect, and the social determinants of health. So it's information that obviously needs to be thought through more. The other thing we were able to do, and one of the important things I think about the atlas, is we are using our current data sets, but really we could do much more in getting better data sets to address and question and ask much more important questions. But if we use, as we did in some cases, the National Morbidity Database, Hospital Morbidity Database, we're able to look at activity by Aboriginal and Torres Strait Islander status and other. And what we saw, when looking at just the preventable hospitalisations, there was a 5-fold higher rate of admission for Aboriginal and Torres Strait Islanders. Now, it's one thing to find the data, raise the profile, make people more aware of this issue of variation and the potential of waste due to unwarranted variation and harm due to unwarranted variation. The next thing is to do something about it. So, yes, the atlas has explored variation. Now the question is, how much of this is unwarranted and how do we address it? And as you can see from the circle, there are 3 aspects that are really important. We want the system to provide data, registry data, i.e. outcome data, perhaps guidepost rates and time series so we can track how we're doing. A key partner in this are consumers, and the Commission has done work on trying to support the system in health literacy and consumer decision supports. And then the third bit is us as clinicians. And I just want to talk briefly about the clinical care standards that the Commission has been doing to try and improve practice. And I'll give you the example of knee arthroscopy. So in the first atlas, we looked at knee arthroscopy for over 55-year-olds. Probably anyone who read the New England Journal about 10 years ago started to see the literature that came out that said knee arthroscopy has no benefit of significance for people who have simple osteoarthritis. If you've got a locking knee or a loose body, that might be different. But the data is quite clearly coming out and saying this is low-value care. What we found, however, was 33,000 knee arthroscopies and a 7-fold variation. So in that circumstance, we were able to do something about that. The clinical care standard brought together clinicians, jurisdictions, consumers, clinicians, rheumatologists, physios, all the people relevant to management of knee pain, and put together a clinical care standard, which is really 7 or 8 high-level statements about priority quality issues that should occur for patients who have osteoarthritis seeking care. And I'll just show you quality statement 7, which at the bottom says arthroscopic procedures are not effective treatments for osteoarthritis of the knee and therefore should only be offered with people who've got a mechanical locking. And knee surgery should really be offered after people have been offered all those other things that we know benefit osteoarthritis of the knee. And it's of interest that in Australia, almost 50% of knee replacements are associated with obesity. So here was an opportunity to get the message out there and to have it, and the College of Physicians has endorsed this standard, and to make the change and make it clear as to what can occur. And I'll just take this article, Not Needed, from The Age in 2018, which looks at the number of MBS-funded surgeries for knee arthroscopy and shows the change. And the media, I think, has been very important in driving some of the discussion in general proactively. But of course, I'm reminded of the line from G.K. Chesterton. Father Brown laid down his pipe and said, it's not that they don't know the answer, it's they don't know the question. So one of the things about looking at variation is you need to be the clinical experts at the coalface, looking at why is it so, what's warranted, what's unwarranted. So in the second version of the standards, under the governance standard, is now a standard 1.28, which asks health services to ensure that they're monitoring variation in practice against expected health outcomes, that they're providing feedback to clinicians, they're providing the data to clinicians so that clinicians can be starting to really drill down on their data to know where they have variation, what's warranted and what's unwarranted. I think this makes lots of sense, and Denham and Ostrom always believed that that at the coalface is where a lot of change could be made. Of course, with continuing professional development, that is going to change in the future, and that too makes a lot of sense. It's asked us in the future to, at least 25% of the time, to be reviewing our performance, measuring our outcomes. And of course, that's where the system can help if it's providing data. And that's why I say it's a triumvirate working together. So why examine personal performance and measure our outcomes? Well, anyone who's old enough to have been around the days of the House of God and read the House of God, rule 1 was if you didn't take a temperature, you can't find a fever. If you never look, you'll never know. And the reason, of course, is data about our patient outcomes should drive our care. It should inspire us to see what we do well, and it should teach that to others, and to understand what others do better and to learn from them. There's good examples internationally that if we get data back and in a timely fashion, it makes a change. So this is from the Swedish cardiac register, where over time they fed data back to hospitals and individuals. And as you can see, the amount of adherence to best practice improved when people got feedback. So there is a real role for us to work with our jurisdictions, with our hospital administrators, with our data managers, with our IT, to get into a situation where we are getting our data, can get it back, and can answer those questions about variation and whether it's warranted or unwarranted, and move towards more appropriate, high-value care. The other key player in the system, of course, are the consumers. And I think they're having a tough time, but it's important that we actually remember consumers and how hard it is to understand healthcare, and how we as clinicians need to do more to improve their understanding. And the Commission has done a lot in that regard in terms of providing information on health literacy and patient-centred care and decision support. We have moved on. This is an old ad for aspirin, and one of the interesting things about it is that we all know that the media is becoming very important in healthcare and driving a lot of discussion. Now, this old aspirin ad is pretty easy to debunk. It says it's safe. Well, we know that's not, and we've actually got the capacity to analyse, because of all those developments we've made in healthcare, to know what the evidence is. It says it doesn't affect the heart. Well, we've got much better at that. We know that it does. But I think we're now in an environment where advertising is very powerful, and the internet is very powerful at driving anxiety among consumers. So this ad from the New York Times of 2012, which says if you have skin, you're at risk of melanoma, I think is designed to make people anxious and to drive people towards seeking medical care and seeking treatment. And for the consumer, that's really hard to know what's good care and what's not good care. And that's going to be the biggest challenge, I think, for us in the future, to establish how we educate consumers so that we're not being driven to provide low-value care. Samuel Gray, who started the atlases of healthcare variation in the UK, said, we need to think about healthcare, really, how you practically do it in terms of unwarranted variation, is you just think about whether it's high value or low value, whether it's provided or not provided. And if you're doing it and it's high value, keep going. If you're doing it, if you're providing it and it's low value, then for God's sake, stop. If it's high value and it's not provided, well, you need to start. But the most important thing, if it's low value and it's not provided, stop. And I think in many ways, when we think about stopping doing low value care, there is so much that we can do that is high value. But on the flip side, as Peter Drucker says, there is nothing so useless as doing efficiently that which should not be done at all. So I think in this era of disruption in healthcare, the dog has got it right. He says we need to do things differently. We need to think, innovate, and I think we have the capacity to maintain the health of the commons by looking to reducing unwarranted variation. Thank you.